they were using screens to access social media, or they were accessing screens to watch online streaming platforms. There was a section of population for whom increase in screen time meant that they were more interested in searching for alcohol and alcohol related themes online as well. Next, please. So what it meant was that when you are thinking and you are discussing an issue of increase in screen time in context of COVID-19, it meant that you are not just talking about a certain set of behavioral disorders that have kind of emerged or that have increased in terms of their prevalence or increase in terms of people spending extra time over screens. There was a potential that there was an interaction of this increase in screen time with certain addictive behaviors or addictive disorders as well. For example, in case of alcohol, there was an increase in interest in terms such as alcoholic beverage, beer, whiskey, vodka, and how to even prepare these beverages at home. So what it meant was that while a lot of increase in screen time was being attributed to increase in behavioral addictions or children and adolescents excessively engaging themselves into excessive gaming, a large proportion of this increase in screen time could potentially be attributed to people who were consuming alcohol or who were interested in themes or attributes related to substance use disorders. So what it meant was, when people started coming up with recommendations how to handle the screen time, or when people started to talk about what screen time increase means and how it can influence you, this particular aspect was kind of getting overlooked or getting ignored, and people were not actually thinking or talking about that there might be a section of population who is accessing screen excessively because they are interested in certain behaviors which are probably not behavioral addictions, and they might be a reflection of other underlying mental disorders or substance use disorders. Next, please. So this is what actually
there any more? Any more?
There's just have been a slight problem with Mr. Balhara. He went out of the conversation somehow. We're just gonna wait for him to log in again. Thank you.
Background.
Mr. Casas, would you like to
Sorry?
would you like to take it over?
Sorry. What must I do, sir?
Can you just step in meanwhile? Mr. Balhara somehow logged off the session, so we're asking you to step in.
But I don't know how to manage this. Can you ask?
He's back. He's back with us, so he's gonna step in. Thank you.
نمشي بكيزي عندك مشكلة في طلبك.
Nadia?
Yes. Mrs. Nadia, can you step in because Mr. Balhara seems to be having a problem with the internet. So can you step in and present the next speaker, please? Thank you.
The next speaker is here. Shall I present the next speaker?
Something wrong also with my computer. Yes, please introduce the next speaker, please, Nadia.
So we have some problem difficulties with our first speaker, and we are obliged to introduce the second one, waiting for the Mr. Hunt to become with us. And our pleasure to present, to introduce Mr. Khan, who will present the following presentation: intellectual disability and behavioral disorders, the diagnostic challenges.
Kadri, I'd like to say that Mr. Khan is not within us yet.
So what may I do?
There on the program there is Mrs. Blecha that's next. If it's okay with you and with her also, we can take off now.
Madame Blecha, you are with us? Madame Blecha?
Yes, I'm here. Yes, I'm here.
So, shall I start?
Let's go for it.
Okay. So, unfortunately, we have to wait that the first speaker become with us. And waiting for that, we are I'm pleased to present Madame Blecha. She is working in France, Paris, in Centre Études et Recherches et Enseignement Traitement des Addictions, University of Paris, Saclay. She is praticienne hospitalière and also working in organic field in the Centre Hépato-Biliaire with program de greffe. Pleasure to hear you, Mrs. Blecha.
Okay. Well, thank you. I would like to thank the World Association of Dual Disorders for their kind invitation to allow me to speak on the subject of infectious diseases and dual disorders patients. I'd like to focus my talk on viruses, inflammation, more specifically, and what some familiar diseases may be able to inform us on the outcome of dual disorders patients, especially in the time of COVID. Next slide, please. So let's start off with C. hepatitis, something we all know a little bit about. Next slide, please. So this year's Nobel Prize in Medicine went to the discoverers of the C. hepatitis virus. So especially Michael Howden characterized the viral RNA using novel replication technology. And this technology is foundational in our current PCR COVID tests. Now, what gives me some comfort at the moment is that within the span of my career, scientists have not only identified the source of this disease, but they've also been able to find the means of treating it, initially with interferon, and today with direct-acting antiviral medications. We can cure up to 99% of all patients who have C. hepatitis. Next slide, please. So, this is the natural history of C. hepatitis infection in the liver. So most primo infections are, of course, very mild, and progressively over the span of 20, 30 years, patients will gradually develop increasing liver complications. Next slide, please. However, what is really important to remember is that chronic HCV has many other consequences, including cardiovascular, metabolic. It's a cancer risk factor, and especially what concerns us today is the neuropsychiatric complications that I'd like to spend a couple of minutes talking about. Next slide, please. So the risk factors for chronic HCV progression, of course, are male, older age, alcohol consumption and obesity, as well as metabolic syndrome and fatty liver disease. So we can see that there's some bidirectional risk factors that are going on there. And I do believe that does come into play in some of the neuropsychiatric complications. Next slide, please. So it's important as mental health professionals to be aware that HCV is very prevalent among psychiatric and addictions patients. If only 2% of the European population, general population, has HCV, in psychiatric populations, that may reach 8%, and intravenous drug users, that can reach 50 to 80%. Now, on this slide, as we can see that HCV patients do have a strong prevalence of mental disorders versus the general population. That's all major mental disorders, as well as substance use disorders and fatigue. Next slide, please. So in this review of the literature, we can see that the authors found that patients who have chronic PCR positive HCV infections have clearly modified executive dysfunction with decreased processing speed, working memory, lesser verbal fluency, difficulties shift setting, difficulties in decision making, apathy, passivity, a whole host of factors that can really lead to lesser quality of life and very great difficulties in their everyday life. Next slide, please. This review of the literature also went through some of the neuroimaging findings, which I find absolutely fascinating. And they correlated these executive and attention difficulties with decreased striatal dopamine transporter uptake, diminished serotonin transmission, modifications of the perfusion of the frontal cortex and the hippocampus, as well as atrophy in these same areas. And the diffusion tensor imaging also showed altered connectivity between the different brain regions. Next slide, please. So, an important question, practical, clinical. Is it the virus or is it our immune system's reaction to it? Because this is going to condition the treatment outcomes. Next slide, please. So there's a couple of studies that can give us some elements of response. And this small study, which was among a clinical population from clinical and support groups in Germany, about half of the patients had been treated with interferon, the other half had not been treated, and 2 out of 3 patients were still positive for HCV. Next slide, please. So what we can see and what really stands out on this slide is that any exposure to HCV results in less favorable outcomes than the control population that's in the blue bars. But what really stands out to me is the fact that those patients that had naturally cleared the virus, they were PCR negative, they've never been treated with interferon. So those are the patients that are on the yellow bars on the far right of each column. As you can see, they had significantly less favorable outcomes. Even patients treated for interferon had less favorable outcomes. Next slide, please. So the question is it the treatment modality or is it the direct-acting antivirals that might give us even better outcomes? So in this study, they followed up patients, a group of patients with a history of psychiatric disorders and a group of patients without psychiatric disorders who had undergone direct-acting antiviral treatment. 99% of the patients were cured of their virals, or they were PCR negative. And as you can see, at 12 weeks, there was, on average, an improvement in depression and in anxiety and in the symptoms checklist. However, what interests me is these groups are these patients that are the outliers. The patients that you can see, they're not really improved. Certain patients still have a Hamilton score rating of 23 after treatment, 17 after treatment. And so I have to wonder if we're really improving patients, or what will their mental health outcomes and their long-term quality of life be following HEP exposure. Next slide, please. So I'd like to transition into the COVID, perhaps what we can read into the current COVID situation. So perhaps at first glance, there's not much that's in common between HCV and the SARS-CoV, except that they're both single-stranded, positive sense RNA viruses. They're both potentially chronic. There's a potential for chronic infection, although we have less to go on with the COVID virus. So weakly cytotoxic, what we're starting to think is that perhaps the COVID, it may be more of the immune reaction that's playing a role in the severity of infection. And of course, they're both neurotropic viruses and they have systemic consequences. Next slide, please. So let's take a look at the neurotropism and the neurological symptoms that we're observing in COVID patients. Next slide, please. So, as we see on this slide, that the COVID virus attaches itself to an ACE2 receptor, which is found everywhere in the body. It's found in the lungs, it's found in vessels, blood vessels, it's found in the olfactory bulb, and that may be the potential gateway through which the SARS-CoV gains access to the brain. Other potential routes that have been sort of evoked in different studies are blood-borne or peripheral neurons. So there have been 2 cases in which they did do spinal taps, and they have found SARS-CoV in the brain and in the cerebral spinal fluid. Next slide, please. So the acute neurological symptoms of COVID-19. So loss of taste, loss of smell, extreme headaches, dizziness, cerebrovascular disease is very common. And also interesting are some delusions and hallucinations in the early stages, and especially in some older patients. Next slide, please. So what about the long-term consequences and outcomes? We're very, very, very early in this disease, but what the CDC is showing, and in certain patient surveys, is that 1 in 3 patients and 1 in 3 persons who had initial very mild symptoms are starting to show signs of long-term immune reactions that are really, they're showing brain fog, they're showing difficulties concentrating, depressive symptoms. It may not be such a mild disease after all. Next slide. So this slide may look a little bit familiar. The same risk factors for chronic COVID-19 progressions as HCV. Male, older age upon infection, alcohol consumption, obesity, metabolic syndrome. So I'd like to focus on just 2 of these factors in the evolution and the potential gravity of COVID. Next slide, please. We don't often think of alcohol as having an impact on lung infections. And this has been seen since the 18th century that excessive alcohol use has been associated with increased incidence of pneumonia, tuberculosis, and is associated with pejorative outcomes in intensive care. Alcohol modifies lung function, it modifies the immune system, and I'd like to just emphasize that it activates pro-inflammatory cytokines such as interleukin-6. And interleukin-6 has been shown as a risk marker for COVID severity. So there are few studies, there are almost no studies of the implications of alcohol in the severity of COVID, although I wonder what its implication is in long haulers as far as long-term mental outcomes. Next slide, please. Also, Adipose hypertrophy is associated with modifications in metabolism, and these modifications lead to upregulation of pro-inflammatory genes and chronic inflammation. So these patients that are overweight, obese, do have chronic inflammation, and that may be contributing to some of the pejorative outcomes in acute and potentially in long-term COVID outcomes. Next slide, please. So some of the questions that I do have, perhaps a provocative one. Could depressive symptoms have survival value? Does depression have survival value? Acute depressive symptoms in the context of infectious diseases? Very probably. You don't want to hang out with a lot of people when you're feeling sick and when you have this inflammation. It may protect your immediate friends, family, colleagues. Stay home if you're sick. Could alcohol and substance use have survival value? Perhaps. We've been living as Homo sapiens around alcohol for a very long time, and so that acute boost to the immune system could have an impact, at least on the short term. And the short-term inflammation perhaps has an impact on these depressive symptoms and may protect from viral transmission. However, long-term depressive symptoms, long-term alcohol and substance use, and long-term inflammation could have a significant impact on the outcomes. I'd also like to state that, inflammation in whose brain? Inflammation in a child's brain, a developing brain, the outcomes could be very different from that of an adult's brain. Next slide, please. I'd just like to take a few minutes to talk about this complex societal conjuncture that we're all in. I mean, isn't it an insane time to be alive, where we're experiencing major economic upheaval, social distancing and societal fractures, and a very increasingly fragile mental health and physical health system, a hospital system that has been incredibly taxed, and which could lead to chronic stress in entire populations throughout the planet. Next slide, please. And I suppose as a caregiver, this is probably one of the most disappointing. In fact, in 1963, we were all excited. We were going to get rid of infectious diseases, that we were all going to be free of these viral pandemics. And here we are. Next slide, please. They're still around. The HIV first, then SARS, MERS, Ebola, Zika, and now swine flu and COVID. Although I have to say that each pandemic has presented an opportunity to learn more about these viruses and their impact on human health. Next slide, please. Although as a caregiver, I have to say that I think there's a certain ingratitude in all of this. The 1918 pandemic, we almost never talked about it, a forgotten story. 1914 to 1918, 50 million casualties in the First World War. 1918 to 1920, in the span of 18 months, the same number of lives that were taken throughout the world. Next slide, please. However, I'm sorry to say there will be no memorials for those victims of the flu pandemic, and probably to the COVID pandemic. In fact, just two in the world for the 1918 flu pandemic, one a small park bench in a Vermont cemetery, and another that was commissioned in 2018 in New Zealand by Jacinda Ardern. Next slide, please. Although we don't have very many figures about the long-term outcomes in the COVID patients, we do have some idea from the SARS survivors. So as you can see here, after nearly 3 months out from the SARS epidemic, 40% of those followed in this study still had active psychiatric disorders, post-traumatic stress disorders, depression, panic disorders. there was about nearly 1 in 3 who still had chronic fatigue syndrome, and other small qualitative studies have shown a similar outcome. Next slide, please. So the Ebola outbreak, what we were seeing and what the studies have shown is that survivors really continue to report feelings of fear, shame, denial, survival guilt as well. Zika outbreak, people who had asked for nothing and were victims or who passed on this virus and the consequential malformations to their infants. And even those pregnant women who were living in the same country around that viral outbreak still reported significant stress, anxiety, and depression. And these mothers also reported significant societal rejection. Next slide, please. As healthcare workers during these potentially lethal viral outbreaks, there's still a lot of silence about the experience of healthcare workers. There are fewer studies examining the mental health healthcare outcomes of healthcare workers. Many healthcare workers have an increased sense of resilience and purpose following the experience of working during a lethal viral outbreaks. However, this is not the case for everyone. Some studies have shown that caregivers who were working in riskier and higher exposure situations had greater prevalence of insomnia and depression than those who were in less risky positions. One study showed an increased risk of excessive alcohol use in an attempt to cope with depressive and traumatic symptoms. It's worth noting that studies have shown that workers in lower risk positions with less infected patient contacts still have a higher than average risk of fatigue, poor sleep, and anxiety concerning personal health, as well as fears of contaminating their immediate entourage. Next slide, please. So, can our immune system get PTSD? Sure. Long-term inflammation I do believe, and the studies are showing, can have some serious consequences, especially to the central nervous system. And would this be eventually a common vulnerability risk factor for our dual disorders patients? Part of the variability in the clinical course of these viruses is associated with differing immune system responses. And would that eventually be an interesting endophenotype to be studying in for future research? Exogenous substance may be responsible for enhancing and prolonging inflammatory states, especially when they're used over the long term. And this chronic inflammation may be associated with long-term dual disorders. So I'd like to thank you for your attention. Next slide, please. Next slide, please. Thank you so much for your attention. Stay safe, be well, and I'm looking forward to meeting you at a future conference.
Thank you very much, Dr. Blecha. Nadia? Nadia? Nadia?
Yes, Miguel, I'm here.
I don't know if we can ask Dr. Khan to give his conference.
Yes, they told me from the regie that it's okay. And okay. we can present him.
Okay, you can introduce him. Yes, thank you very much.
Shall I go? So,
yes,
thank you very much, Dr. Blecha, for your interesting presentation that we will discuss during the discussion. And I'm the great pleasure to introduce Mr. Khan, who is professor of psychiatry in Kingston, Canada, and also in the University of Islamabad. And he will present us the following presentation, Intellectual Disabilities and Dual Disorders, the challenge of diagnosis. Mr. Khan, to you.
Thank you very much. So when I was asked to present, I thought that this topic was actually a little bit different. So I wanted to talk about it. Some few thoughts, my thoughts, and some of the data that I was able to gather from various sources. Next slide, please. So I have an advantage of working in the lower middle income country and also in a developed country as well. So the comparison is always challenging for me to see the things, how they are happening in low middle income countries and how they are happening in developed country. And I'm sure that lots of psychiatrists who are working in two different areas, they do have these questions. And this was a big question for me as well, what to do about it and how to go about it. So this is one of the reasons that I wanted to present this. Now, how common is the problem? So when I was just scrolling the data and I was trying to find out to make this presentation, I was confused because it is so difficult to find out an appropriate data related to this problem, the intellectual disability and dual diagnosis, substance abuse and other stuff. So this was one of the slides which was showing the gradual increase in the substance abuse and the change in the substance abuse back in 3 decades. So I just took some of it. And it is showing that in 2010, around the grade 8 level, cigarette smoking was 7.1% and alcohol abuse was 13.8% and any illicit drugs were 9.5%. So considering this problem that in this study, I thought that this is quite a big and significant number. Next slide, please. So if we think about the substance abuse, next slide, please, and correlate it generally, then I do believe that things are complicated. So can I have a next slide, please? Yeah. Okay, thank you. So people with disabilities are a growing health disparities in population. People with intellectual disability face more severe mental, physical, and social consequences from substance use related problems than members of other groups. But the substance use problems and the associated treatment needs among members of this population are understudied. So this is the main problem. We don't know the magnitude of the problem, substance abuse and intellectual disability as such. There is no data available from low and middle income country. Few studies, mostly done in the developed world, and they are also very much less than what is desired. So well-designed theory-driven studies of large samples are needed to establish the base rates of substance use and the disorders related to intellectual disability. Next slide, please. So ID, even though as early as 1932, East wrote about alcoholism in the feeble-minded as a specific population at risk for substance use disorder. So it was recognized. And addiction medicine still little attention to whom we now call individuals with mild to moderate intellectual disability. And intellectual disability is characterized by deficit in intellectual and adaptive functioning that originates in the developmental period. Intellectual functioning refers to a wide range of mental abilities, for example, reasoning, planning, problem solving, judgment, and abstract thinking. It is measured by standardized IQ test, and IQ scores between 50 and 70 are indicative of mild to borderline intellectual disability. In the DSM-5, deficiencies in adaptive functioning, that is, skills that are needed to function on a day-to-day life, for example, the conceptual thinking, interpersonal communication, and practical skills, define whether a diagnosis of MBID is made or not. Now, this is another question in my mind, that when we talk about the IQ and we go for an IQ test, if it is done in a proper way, only then we'll be able to understand the adaptive functioning. But if it is just the rough assessment of IQ, there is a disparity in verbal and adaptive functioning. So how, and this is another reason why probably not much of the studies were done in this area, because the definition for a specific criteria of what is missing and what should be included as an intellectual disability thing with the substance use disorder is complicated. And it further complicates when we are actually treating these people, because then things get more problematic. So I will come to that point as well when I'll be talking about the interventional problems in this population. Next slide, please. So ID people are very vulnerable, and they are involved in multiple criminal activities: murder, robbery, physical assault, sexual assault, and theft. And this is again a common thing which people, most of the psychiatrists, psychologists, and mental health professionals know, that people who are having intellectual disability may be involved in these type of crimes. Next, please. In addition to that, the additional problem is that severe intellectual disability may be identifiable just right at the first clinical interview, but the mild to moderate is unfortunately difficult to be assessed unless or until a thorough, detailed evaluation is administered to these people. Next slide, please. Now, further complication into this situation is added when we talk about the developmental disabilities. Now, this is unfortunate that there are three types of categories. One, developmental disability with intellectual disability, then developmental disability not with intellectual disability, and developmental disability, intellectual disability, but not with developmental disability. Now, this further complicates because more than 50% of the people have intellectual disability and developmental disability. So there are physical signs, there are mental signs, there are emotional problems, and above that, they have substance use disorders as well. So then it's a more complicated situation in as far as we talk about the management. Next slide, please. So at least 1 in 6 men suffer from developmental disability, and 1 in 10 women suffer from developmental disability. Overall, it is approximately 2 in 10 in general population if both sexes are considered. Next slide, please. So now if we talk about the developmental disability and intellectual disability in general population, the prevalence and epidemiology suggest that they are high. Despite not having an appropriate data, it is quite significantly common. Next slide, please. Overall, the challenge for Asia will be to develop a localized base of knowledge by conducting epidemiological studies, modeling after evidence-based practices, and evaluating its effectiveness. By adopting scientific approach and formal publication of the data, intellectual disability standards can be evaluated, managed, and improved in a systematic manner. Otherwise, we will keep on having problems. Next slide, please. So keep on rolling it. So when we talk about the classical models of the addiction, we know that there are biological models. Keep on rolling it, please. Keep tapping it. Unfortunately, this slide needs to be move on. So there are biological methods, there are psychological, there are social, there are other areas of intervention and evaluation in the substance abuse. And I don't want to go into the details of these because we all probably know how we treat the substance abuse disorder. But actually, when practically we are sitting in the clinics and we are trying to evaluate the people who are having substance use disorders, how many times we have assessed their IQ, how many times we have really assessed their developmental disability. Most of the time, we try not to do it because we think that it is job of some other healthcare professionals rather than seeing them. So if they are already diagnosed, then of course the job is easy. But if they are not diagnosed, there are subtle symptoms, then the job is more complex and complicated. Next slide, please. Next. So people with physical and cognitive disabilities have a higher prevalence of substance misuse and substance use disorder, as well as lower treatment rates for both conditions than do people without these comorbidities. Mental and substance use disorder treatment provides many underestimated barriers, and unfortunately, accessibility to the programs for these people who are having compromised intellectual or cognitive deficits is more complicated. And the physical and the cognitive disabilities are not always obvious. Clients with such disabilities have problems, and behaviors associated with some of the cognitive disabilities may falsely be mistaken for willful non-adherence or lack of motivation. Now, this is the key. When we are seeing these people, we think that they are probably non-adherents because of other reasons, but actually it's the way they perceive the things. And providers, we should try to inform each client of the program, whatever the program we are going for, ability to meet or arrange access needs, and should act on access request to help and ensure that the client's disabilities get the most out of their mental and substance use disorders treatment. Next, please. So common causes of missing the diagnosis. One, again, as I mentioned to you earlier, that usually when the client is coming to the clinic, we are just seeing the patients as a whole and assessing the substance use disorder and trying to evaluate the psychiatric morbidity, schizophrenia, major depressive disorder, or any other comorbidity. But IQ assessment or the adaptive functioning assessment is unfortunately missed. So then again, the complication develop. When developing a plan of care and selecting a treatment approach, practitioners should take into consideration the special need of the people with ID. Next, please. Next, please. Need adaptations to group and individual mental or substance use disorder counseling and other services. Need appointment and activity reminders. So these people are not able to process as the normal individuals. So repeated reminders are required. Repeated clarifications are required. We have to make sure that they have processed what the information is conveyed to them. And then this makes things more frustrating and more complicated. So we have to simplify the handouts, simplify the things that we want to know, make them know and understand. So they understand more than what they really do understand. Next slide, please. This complication is unfortunately complicated more because of the life expectancy. Now, in the developed country, people with the intellectual disability and the developmental disability, even if it is coexisting, the life expectancy is much higher. So these people do live beyond the expected age what they are living in low and middle income countries. In low and middle income countries, unfortunately, people with the developmental disability and intellectual disability are not seriously taken for a longer period of time, and they usually have much lower life expectancy than anywhere else. And again, as there is no concrete data available for it, so I won't be able to tell you precisely how it happens. It's most of the clinical experience, and I think there is only one research paper which indicated that the people in the lower middle income countries with these disorders, they live shorter. Just one. Next slide, please. So interventional problem, as I mentioned earlier as well, there are multiple. Because of the understanding issues, the things are more complicated. When permissible and appropriate, supplement the client support with input from the family members or the care providers. Go over the group rules, sum up the previous session, repeat important questions and points. If needed, give the individual with the cognitive disability a short break, convey key ideas visually, incorporate role-playing and skills practices, and after each session, see whether clients with cognitive disability understood the key points or not, because they have difficulty in processing. Next slide, please. Why underreported? Only 3 of those have reported the prevalence of MBID in addiction medicine, indicating that around 30 to 40% of the patients in addiction medicine have MBID, mild to borderline intellectual disability. Now, this is a very high number. So if we consider all of the people who are having the substance use disorders, so 30 to 40% means every third person is probably having the intellectual disability, which gives us another insight how to manage them. All other articles reported data on the prevalence of substance abuse or substance use disorder among individuals with MBID. These data are difficult to compare due to different in population. So even the IQ testing formally done by a mental health professional is not able to highlight across the population from which kind of disorder, intellectual disability they are suffering and how much it is correlated with the substance use disorder. So we need something very specific to understand this problem. Therefore, the reported prevalence rates often differ profusely across the studies as well. Next, please. So among the children and adolescents with MBID, the lifetime prevalence rates range from 49.8% for tobacco use, around 70% up to 70% for alcohol use, and 13% cannabis use. Now that the cannabis is legalized in a number of countries, these problems are multiplying as well. So the cannabis use disorders are actually rising. And this young population with dual diagnosis and intellectual disability, it is more complex and complicated. And this seems to reflect a widely held belief that individuals with MBID live there sheltered from the dangers of the society and refrain from potentially hazardous activities. Now, when they are into substance abuse with intellectual disability, they are secluded, isolated, and they refrain themselves from going into public and sharing the information as well, which makes it again more complicated for the treatment and interventional strategies. Next slide, please. So what are the characteristic subset disorders in the persons with the development disability? Level of education is less, usually in this population. Marital status, usually they are single. Age of onset is usually early or late, but again, varies. Crisis-related issues are high. and the individuals with DD have developmental disabilities have become chemically dependent, more difficult to treat effectively with short-term intervention. So they need long-term intervention. And who will invest the money on people who are actually on the sideline of the society? So they are having psychiatric morbidity, substance use, and intellectual disability. More complicated. So outcome and prognosis compromised. Next slide, please. So diagnostic tools availability. If you talk about all the low middle income countries, the tools that are used to assess these people in these countries are not, unfortunately, very much validated and reliability have tested as well. They are adopted from the Western or developed countries, but unfortunately, implementing them in specific population with the local dialect and language is still a challenge in a number of low middle income countries. It is because of the lack of these professionals available, and it is because of the lack of availability of resources and finances as well. Next slide, please. Challenges in the community with deinstitutionalization. So previously, most of these individuals with developmental disability or intellectual disability were institutionalized because they were having a chronic ailment or problem. And after the deinstitutionalizations, they were thrown out of in the community without an appropriate measurements, especially in low and middle income countries. And now these individuals are on the street. And if you talk about the internally displaced people, if you talk about the internal, again, general rate of the crime and other situations, you will find that this is high in this kind of a population. Next slide, please. So again, I mentioned to you that they are having less education, initiation of the substances is early, and unfortunately, psychiatric morbidity is high. Next slide, please. This is very saturated slide, but just to give you an idea, if you look at it, the slides, the data from some of the countries I tried to gather in this slide was Kenya, Afghanistan, Thailand, India, Kosovo, and Croatia. And even these, the data, appropriate data is not appropriately reported as it should be reported otherwise. Next slide, please. And this is not very long ago. This is about 2010 and 2017. So unfortunately, this issue is there. And then economical issues. In the low middle income countries, the economical issues are quite significantly high. So managing these people in the long-term basis is getting difficult and difficult. We are trying our best to provide the resources in a way that this issue should be addressed, trying to develop some strategies to gather the data as well. But unfortunately, still stuck with so many things mentioned in this slide, like organizational environments, the consumers, the resources, the stigma, and lots of government input. So we are still trying to do something out of it. Next slide, please. So in the end, I will just sum up the presentation that when we talk about intellectual disabilities, we talk about developmental disabilities and the substance abuse, we see higher crime rate in this population, more poverty in this population, hunger, availability of the substances, which is much cheaper now. If you talk about the general substances which are now legalized, then stigma, life events, more life events, domestic violence, and resources are very scarce, and psychosocial issues and diagnostic issues are consistent. Last slide, please. Next. So we need some resources where we can collect the data, sum them up, and then make sure that this data is appropriate to be presented to the policymakers to do something about this target population. This was my presentation. If there are any questions, I'll be there to respond to them. Thank you very much.
Thank you very much, Dr. Khan. It's my pleasure to introduce now Dr. Lola Peris, Spanish psychiatrist, well-known Spanish psychiatrist, but living for many years in Switzerland, and now being the head hospital of psychiatry in the Centre Neuchâtelois, Neuchâtel, à la Suisse, in Switzerland. She will talk on the role of sleep and sleep disturbances in dual disorders. Dr. Peris, please go ahead.
Thank you, Miguel. It's okay, can you hear me?
Yes, please.
Yeah. Thank you. So, good morning, good afternoon, and good evening for everybody. And I'm glad to be here to talk to you. I would like to talk about the role of sleep and sleep disturbances in dual disorders. I had proposed this subject because I think it's more and more important the relationship that we know more and more things about the relationship between sleep and dual disorders. Next, please. I don't know if you're aware of the new international classification of diseases, the 11th version that will appear next year. And in this new version, they have included sleep disorders as a new category, which indicates how sleep problems, sleep disorders are becoming more and more important in the treatment of our patients. Next, please. In relation to psychiatric disorders, we know now that sleep disorders are related to the risk of developing different psychiatric disorders. And although we don't know still the causal relationships, but we know that several common neurobiological abnormalities exist. And which is clear now is that in those that have sleep complaints, there's a much higher prevalence of psychiatric disorders. And also those that show at the beginning only sleep complaints, 1 year later, they show a greater rate of new psychiatric disorders. Different studies have been developed and they have associated sleep problems with many psychiatric disorders like major depression or anxiety disorders, substance use disorders, autism spectrum disorder, bipolar disorder, schizophrenia, or ADHD. And as research advances, there's also proposals now to develop methods for using sleep as a therapy for different psychiatric disorders. Next, please. We know now that REM sleep and slow wave sleep have a significant role in memory consolidation, also in cognitive function and affective regulation. That means that they're implicated, they have implication for psychiatric disorders. And also we know that the same neurochemistry that controls the sleep-wake cycle has been implicated in the pathophysiology of different psychiatric disorders, including substance use disorders. So this may explain why so many psychiatric disorders have the sleep complaints as really a first or primary symptom. And if we are able to understand those mechanisms, we will be able also to improve the care of our patients. So that means that psychiatrists and mental health professionals should really be interested and suspect a for several sleep disorders that could be comorbid or mimic psychiatric symptoms. And also we should be aware that different things that we do when we are treating our patients could provoke in some way a problem of sleep. And mainly be aware that if we don't treat these problems, the continuity of difficult, disturbing sleep may exacerbate the underlying psychiatric symptoms. Next, please. Just to show you, this is a paper published this year from, it was a group of Norwegian researchers, and they show how high to moderate partial sleep deprivation is associated with increased impulsivity and decreased positive effect in young adults. And if we think about vulnerable people, this should be even worse. Next, please. This is what I was saying about that we should take care or have in mind that we could influence sleep with the treatments we are using. In this slide, it's in relation to antipsychotics. And if you see, depending of the substance, we could suppress more or less REM sleep, or increase slow wave sleep, or shorten sleep, onset latency, etc. So we need to be aware of the potential consequences of our treatments on sleep. Next. As there's, as I was saying, there's more and more interest on sleep in relation to psychiatric disorders. This is also a paper that was published this year in Lancet Psychiatry. And authors summarize some specific points by saying, for instance, that sleep disturbances is ubiquitous in mental health presentations and is likely to be a contributory causal factor in the presence of most mental health conditions. And they speak about insomnia because it's a more frequent sleep disorder, and they affirm that in the context of mental health disorders, it can be successfully treated. And when sleep problems are treated, mental health problems tend to lessen. So patients would benefit from mental health services that incorporate this routine evaluation and treatment of sleep problems. And that means also that we will have probably the need to greater training on disrupted sleep and also about its treatment. Next, please. Focusing on addiction and dual disorders, the relationship between sleep and addiction and dual disorders is probably the strongest example of this interaction. We know that sleep problems are more prevalent in people using or with a dependence on substances, and also that those with sleep problems have a higher risk of developing substance use problems than the general population. So sleep problems and in substance use disorders could appear as a direct effect of the substance or as a result of withdrawal. And also pre-existing sleep problems could help to develop an addiction. Next, please. This is to show how circuits for sleep-wake regulation and drug reward related encoding overlap. And if you see in the lines about the established incentive saliency pathways and those that are hypothesized both in red, and sleep-dependent motivation pathways established or hypothesized in blue, they really overlap. It's really interesting. Next, please. So there's a growing body of evidence that substance use disorders share a bidirectional complicated relationship with sleep, and that sleep disturbance could be or the precipitant or the consequence in relation to alcohol and drug use. Talking about the precipitant, some findings suggest that a history of baseline insomnia may be predictive of disorder substance use. And also it's interesting, some studies with adolescents, abstinent adolescents that had a family history of substance dependence, and they are more likely to experience difficulties sleeping, which could illustrate or a psychosocial factor or the genetic factor, or maybe both. And it's also really interesting that when now we're talking mainly about alcohol, and patients who are abstinent and will try to predict the likelihood of relapse during the long term. The objective and subjective measures of sleep would predict better than the abstinence in the long term than variables such as age, employment, severity, hepatic enzymes, marital status, or depression ratings. Next, please. Also, just to show that research is really, we're advancing, we're in the beginning, but things are very, very interesting. There's a lot of studies focusing on clock genes and the relationship with sleep problems and dependency. Also, some neuropeptides have been implicated, especially orexin, in this dual role of sleep and reward circuitry. And in the brain, mainly the lateral hypothalamus that contains many of the neurotransmitters and the neural networks that are involved in also in alert, but in concentration and mood and regulation of sleep, and connected with the networks related to reward. That means that they're all connected and related to this, especially to the hypothalamus. Next, please. This is to show, it's a conceptual model that was developed by Hasler and colleagues to show the potential relationships between circadian system and sleep system and substance abuse, indicating which is pathways that are really well known, and those arrows that point the relationship between the sleep system and substance abuse. And those dotted arrows indicate that we need still more research regarding, for instance, the influence of circadian system on substance abuse, or how the circadian system by the mediation of reward processing could also influence substance abuse. Next, please. I won't go deeper in this slide, but it was also to show how the circadian molecular clock may interact and influence the stress axis. In the left side, you see the mammalian circadian molecular clock, and on the right side, how it can interact with the stress axis through regulation of the activity of glucocorticoid and its receptor. Next, please. Before I was talking about the orexin system, which has a role in the rewarding effects of drugs, in addition to its role in arousal. The orexin could be engaged specifically in substance use during, it's considered at least during elevated motivational states. So orexin could help in attenuating drug rewards and improving sleep disturbances by preventing both the potentiation of reward and arousal. And as you know, there's an orexin antagonist, suvorexant, which is approved for the treatment of insomnia, and is being evaluated now for the treatment of substance use disorders. So one of the first steps to advance should be to identify how the circuits and substrates that regulate sleep and arousal intersect with those that mediate rewards and how they are targeted by drugs. Next. Insomnia is the most prevalent sleep disorder, and it's considered a disorder of hyperarousal. That means in part an HPA axis dysfunction involving corticotropin release hormone and norepinephrine. And we know that stress may increase the vulnerability to addiction, and the activation of circuits, brain circuits involved in stress would activate the dopaminergic brain motivational pathways that we know that could be engaged by drugs of abuse. And also we know that the causal role of mesocorticolimbic dopaminergic activity in sleep and wakefulness. So it's also to show another line of knowledge and interaction in relation to psychiatry, substance use disorders, and sleep. Next, please. Probably the substance use disorder more studied in relation to sleep is alcohol use disorder, and it's interesting to see that there's problems and at every stage of this disorder. For instance, if we think about patients that have an active alcohol use consumption, they may have a comorbid sleep disturbance from 30 to 80% of these patients, while in the general population, around 10 to 15% experience insomnia. If we think about acute withdrawal, 50% of patients report sleep problems during withdrawal from alcohol. In early recovery, it could be a problem in the sense that some patients experience for the first time insomnia when they don't have they're not drinking, and also when somebody with a history of chronic alcohol use decides to stop drinking, there's the possibility to recover a restorative sleep, but for some patients, sleep problems may persist for years, and that could increase at the end the vulnerability to relapse. And also another thing is that sleep problems could precede the development of dependence. And there are studies that suggest that a slow wave deficiency may be associated with the development of alcohol dependence. Next, please. So, regarding research and research needs, we are seeing that the sleep disturbances experienced early in life may precede and or predispose the development of substance use disorder, and a growing number of studies support the bidirectional component between sleep patterns and substance use. But although we know that this neurobiological link between both problems, really research is in its beginnings, and there's a lot of things we don't know. For instance, how the interaction between sleep and substance use is modulated by genetics, life events, sex, or circadian rhythm. Next, please. But now, what we said, the things that we know now, what could we do with the treatment of our patients? We should think about sleep problems. We should consider sleep problems, because if we treat them, it may improve the outcomes. So when we see, we should evaluate, and when we see there's also a sleep problem, we should treat both situations, both conditions at the same time, the sleep problem and the dual disorder. And also in these questions, there's a big need for clinical trials focus on the treatment of sleep complaints in substance use. Next, please. In any case, it's as always, there's the published studies in this field have referred mainly to psychiatric patients or substance use disorder patients, and only they indicate only in a marginal way the possibility of co-occurring disorders. If we think about this interaction between a sleep problem and a dual disorder, it's clear that it adds much more complexity to the equation. Next, please. So in relation to this situation, we decided to do first study focus on sleep and dual disorder patients. We wanted to investigate the frequency and severity of sleep problems 1 month prior to admission for control withdrawal. So we had 47 patients with dual diagnosis that were hospitalized in a dual disorders unit. We did a complete psychiatric evaluation and admission, and none of the patients had an acute exacerbation. When the withdrawal was resolved, a set of administered questionnaires evaluating the sleep habits and sleep patterns were presented to patients, and also a specific sleep disorder questionnaire and questions related to symptoms evoking restless legs, parasomnia or hypersomnia. And we evaluated the potential existence of anxiety with the GAD-7. And we collected also, of course, data on demographic and functional variables, substances of use, including the drug of choice, data about psychiatric and medical conditions, actual medications, and duration of the hospitalization. Next, please. To resume the main results, we found a higher prevalence of insomnia symptoms among men in our sample that could have been associated with their higher incidence of anxiety. Disturbed sleep was highly prevalent among patients abusing a substance, regardless of the type of that substance, although with no statistical significance, but those consuming alcohol or cannabis declare higher sleep onset latency. Patients who had a polysubstance use, which almost 60% of them had a personality disorder diagnosis, did not associate the use of substances or relapse with sleep difficulties, which is a question that would worth exploring further. Same thing that the following one, the absence of daytime functioning alteration by poor sleep. And addictive behavior was engaged in more than half of the patients prior to receiving their main psychiatric diagnosis, which is not a strange question, but which is interesting is that the addictive behavior was engaged close to the beginning of their sleep problems. Around 70% of cannabis and alcohol users declared starting their substance use after the development of insomnia. Next, please. So to conclude my presentation, I will in fact use the conclusion of our study. Dual disorder patients face important sleep disturbances with low sleep quality, and we need to do detailed sleep evaluations and to find strategies to diminish these sleep problems, because it's very helpful in the evolution of these patients. We need further studies to answer the role of sleep in addiction and dual disorders that will support the importance of a good quality of sleep together with stabilizing the main psychiatric disorder for diminishing the frequency or the severity of the use of psychoactive substances in these patients. And it's clear that research advances on sleep disturbances in the context of substance use and dual disorders may really improve the knowledge of the etiology of substance use disorders, and then in the methods of prevention and treatment. So this was my presentation. Thank you for your attention.
Thank you very much, Dr. Peris, for your very important talk. I am absolutely convinced that sleep disorders has an important role in the genesis, in the etiopathogenesis, and also in the continuity of all dual disorders. Thank you very much. Now, it's a great honor to introduce Professor Leo Sher. Leo Sher is a professor of psychiatry at the Icahn School of Medicine at Mount Sinai, New York, and director of inpatient psychiatry at the James J. Peters Veterans Administration Medical Center. Professor Leo Sher also has a peculiarity. It's a psychiatrist with a very strong background in internal medicine. And when you talk with him, you notice very rapidly that he is a psychiatrist and also a doctor, a real classical doctor. That is very good. Professor Leo Sher has been always linked to the Spanish Society of Dual Disorders, and now is also very engaged in the World Association of Dual Disorders. Professor Leo Sher, you will talk on dual disorders and suicide during and after the COVID-19 pandemic. Please.
Hi. Thank you for your kind words, Professor Casas. Thank you for your kind introduction. I also would like to thank the Congress organizers for inviting me to give this talk. The topic of my talk is dual disorders and suicide during and after the COVID-19 pandemic. Next slide, please. So, as you know, suicide is a very important social and medical problem. And at least 1 million people die by suicide across the world, according to the World Health Organization and according to other data. It means that every 40 seconds, an individual dies by suicide somewhere in the world, and many, many more people make non-lethal suicide attempts. Next slide, please. Studies in the United States suggest that more than 90% of victims of suicide have a psychiatric disorder. This number, more than 90%, is based on psychological autopsy studies. Of course, most people who attempt suicide have also a psychiatric disorder. The most frequent psychiatric disorders associated with suicide or highly lethal suicide attempts are mood and psychotic disorders. However, alcohol and drug abuse, anxiety, and personality disorders, including antisocial personality disorder and borderline personality disorder, are also associated with an elevated suicide risk. Medical conditions, especially illnesses associated with chronic pain, significantly increase suicide risk. Next slide, please. And next. Thank you. Suicidal behavior is a continuum of different types of self-harm, and it may include suicide attempt, failed suicide, and aborted suicides. Suicidal behavior is a continuum, and suicide intent may be different, and lethality of suicide attempts is frequently very different. Next, please. Essentially, it has been postulated that suicide is related to combination, to a coincidence of a predisposition to suicidal behavior and a trigger. for suicide. In other words, some individuals have a predisposition or vulnerability to suicidal behavior, to attempt or commit suicide. And if their mood is unstable, if they're acutely intoxicated, for example, with alcohol, or there is a financial distress, social disruption, and in young people it may be a case of contagion, if there is a trigger, so people may attempt to commit suicide. I would like to note that among physical illnesses, pain syndromes are very important as precipitants uh, of suicide attempts and as factors affecting vulnerability to suicide. In short, suicide is a coincidence, is a combination of a predisposition to attempt or commit suicide and a trigger that may uh, lead to suicidal act. Next slide, please. Patients with dually diagnosed mental illness, major mental illness, and substance use disorder are at high risk for suicidal behavior. It could be, of course, expected because major mental illnesses, such as major depression or schizophrenia, are associated with suicidal behavior, and alcohol and drug abuse are also associated with suicidal behavior. So there may be here, there may be an additive or synergistic effect. If, for example, it has been shown that substance use disorders are a significant predictor of suicide attempts in patients with bipolar illness, and the risk of suicide in patients with comorbid bipolar illness and alcohol use disorder is about twice that of those without alcohol use disorder. In other words, the presence of alcohol use disorder increasing suicidality in patients with bipolar illness. Also, it is important to note that patients with dual diagnosis are also more likely to have medical and neurological comorbidities, such as pain disorders and traumatic brain injuries, including mild traumatic brain injuries, and increase this further increases risk for suicidal behavior. Next, please. The COVID-19 pandemic and public health interventions aimed at reducing the spread of the coronavirus have profound psychological and social effects around the globe. And these effects include anxiety, fear of contagion, feeling of uncertainty, chronic stress, and economic difficulties. The economic impact of COVID-19 is very important, and it's very significant and it's tragic. The COVID-19 global recession, including job strain and insecurity, severely increasing unemployment and lengthy periods of unemployment, bankruptcy, increasing family debts, deterioration of asset values, loss of savings, reduced healthcare resources, and reduction in social services significantly affects the psychological state of millions of people worldwide. The COVID-19 pandemic may increase the prevalence of psychiatric disorders and suicide rates during and following the pandemic. And unfortunately, it probably will increase. Next slide, please. The COVID-19 pandemic may lead to relapse or exacerbation of pre-existing dual disorders and to the onset of new dual disorders. The COVID-19 crisis is associated with anxiety, fear of contagion, uncertainty, social isolation, chronic stress, economic difficulties, and other psychosocial issues, which may lead to relapse or worsening of depressive, anxiety, substance use, and other psychiatric disorders in vulnerable populations, especially in individuals with dual disorders. Next, please. For example, a recent study in China showed that during the COVID-19 epidemic, a lot of abstinent alcohol users and a lot of abstinent smokers relapsed. Or in addition, about 1/3 of regular alcohol drinkers increased alcohol consumption, and many, about 20%, of regular smokers increased smoking during the pandemic. Also, the American Medical Association reported in July that more than 35 US states reported increases in opioid-related mortality during the COVID-19 pandemic. And next slide, please. Next slide. It looks like a perfect storm situation. The COVID-19 pandemic may increase suicide risk in persons with dual disorders who are already at elevated suicide risk. The COVID-19 pandemic may increase suicidality among patients with dual disorders during and after the pandemic. Next slide, please. So basically, this slide shows a possible mechanisms or a possible, of course, it's a simplified description of the situation, but this slide shows how suicidal behavior in individuals with dual disorders may be developed in the COVID-19 era. COVID-19 is associated with multiple problems, as I mentioned, including uncertainty, social isolation, and economic problems. All these factors affect the general population, including individuals with dual disorders. So this situation may lead to exacerbation of non-addictive psychiatric disorders and exacerbations of substance use disorders. And this combination may increase a probability of a suicidal act. Next slide, please. So what should we try to do to reduce suicidal behavior, to reduce suicides among individuals with dual disorders in the stressful COVID-19 era? Of course, we need to try to improve recognition of dual disorders. Unrecognized and untreated individuals with dual disorders may be at especially high suicide risk. This task is, one moment, please go back. Thank you. May be at an especially high suicide risk. And of course, it is important to note that the COVID-19 pandemic affected psychiatric practice around the world. Many psychiatrists see patients remotely, and it probably reduces the quality of care. Needless to say that COVID-19 pandemic essentially disrupted mental health services around the world. In some countries, in some areas, this disruption is very significant. In some areas, it's less disrupted, but it's affected because medical care for COVID patients and public health measures to reduce the spread of COVID-19 are regarded by many people more important than psychiatric care and suicide prevention, unfortunately. So it's not an easy. The second is that we need to screen dual disorder patients for suicidal ideation. In general, we should assume that people with alcoholism and depression are generally comorbid alcoholism and depression, it's an example, are generally at elevated suicide risk. We need to adequately treat dual disorders, of course. We need to prevent a relapse when the patient is in remission. And this is especially important nowadays in the stressful COVID-19 era. Obviously, we need to treat comorbid. We need to treat comorbid medical and neurological disorders, especially pain disorders, of course. We need to provide this social support. It is vital to reduce social isolation and loneliness associated with COVID-19, with the COVID-19 crisis. We need to provide dual disorder patients with information about suicide prevention hotlines and other available mental health resources. In this regard, I want to tell you that it has been decided that there will be one 3-digit suicide prevention hotline number in the United States for American people, of course, starting approximately in the middle of 2022. It will be the number 988. It will be a number to call suicide prevention and mental health crisis hotline in the United States. Currently, it's a 10-digit number that is obviously more difficult to remember than 988. It will be like emergency mental health number 988 in the United States, starting in about 2 years. Of course, I'm returning to this slide. Of course, it is important to reduce access to lethal means, if possible. We know that if lethal means are less available, in many cases, it will reduce suicides, especially in impulsive individuals. And we know that many individuals with dual disorders are or may be impulsive people. We know this. Next slide, please. Psychiatric consequences of the COVID-19 crisis, including increase in suicides, will probably be present for a long time and peak later than the actual COVID-19 pandemic. Although suicide prevention is a very difficult task, clinicians are expected to make every effort to prevent suicide in our patients. Next slide, please. We ought to promote the highest standards of research and scholarship in the field of suicidology by fostering communication and cooperation among scholars around the world. We need to build a dynamic, interactive, global community of suicide researchers to advance scientific excellence in the COVID-19 era by providing a framework in which the suicidologists can convene, collaborate, and integrate. Next slide, please. And this flower is my gift to you, to the listeners, to thank you for listening to my talk. I would like to thank the Congress organizers and especially Professor Miguel Casas for inviting me to give a talk at this interesting and important Congress, this interesting and important event. Thank you for your attention.
Thank you very much, Professor Sher, for your very important talk, really. It is clear that we must be very aware on the high risk of suicide in our patients. And sometimes we do not consider this possibility. Thank you very much. Well, as the last speaker, I have now the pleasure to introduce a good friend, Professor José Martínez Raga, which is head of psychiatry in the Hospital Universitario Dr. Peset in Valencia, Spain. He's professor in the Universidad Medical School in Valencia, and is also vice president of our Society of Dual Pathology. He has been very engaged far from the beginning in our society and now in the World International and the World Association for Dual Disorders. Pepe, you can start. Thank you very much.
Thank you. Thank you very much, Miguel, for your kind words. Very pleased to be here. Let's see if I can. Okay. Yeah, I'm grateful to be in this Congress, to participate in this Congress, and I would like to thank Professor Mehdi Paez for inviting me kindly to participate in it. I'll be talking about ADHD because this is one of my areas of interest, has been in the last years, jointly with dual disorders. So I'm very happy to be able to talk about this issue. But as Dr. Sher, as Leo was saying, and we've been talking about along these sessions, so we are in difficult times. And please, the next slide, where COVID-19 has actually marked all our decisions, all our clinical activities, all our research activities. And it's actually quite odd to be in front of a computer when we would be enjoying the wonderful weather in Marrakesh and great company. But it looks like we're here to stay for a long time. And so therefore, it's important to understand where we are. And there are some recent papers that actually helps us to face this situation and to realize where we are. And so, and one of these areas is actually, well, how are individuals' mental illness and with dual disorders and with ADHD doing with COVID. And a very recent paper from Nora Volkov and from data from over 60 million adult patients, electronic health records actually showed that individuals with mental health problems are more at risk for COVID-19 infection. And as we'll see in the next slide, individuals with schizophrenia, with depression, with bipolar disorder, and the topic of today, ADHD, have an increased risk, which varies from 7.3 in ADHD to 10.4 in depression, all controlling after age, gender, and ethnicity. This is extremely high and points out, focusing on ADHD, that these are very vulnerable population. Please, next slide. The same applies if we're controlling even further with medical comorbidities and ethnicity. That is still the odds ratio, the probability of engaging with COVID-19 is 5.6 compared to general population. Next slide. And this is without any gender differences, significant gender differences. Next slide. But, and this is, next one, please. And this is in concordance with also another very recent study from Israel showing that in a sample of 14,000 individuals, people with ADHD had a 52% higher risk of being ADHD positive. That means with an odds ratio of 1.6. But not only that, that this was ADHD overall. Now, those individuals in treatment, the odds ratio went down to 1.07. So treatment actually protects, as we know happens also with the risk to substance misuse. Next slide. Next one, please. And no, sorry, the one before. Yeah, and again, data from that gathered Nora Volkov in a study with 73 million electronic records show that not only individuals with other mental disorders, but also individuals with substance use disorder had an increased risk to develop or to be infected with COVID-19 with an odds ratio of 8.7. This therefore, especially this is particularly important because individuals with substance use disorder are more likely to have either chronic kidney disease, liver disease, lung disease, or other types of. So I hope you can hear me. I'm not getting any feedback, but as I said, then it's important, however, that this risk to have a diagnosis of COVID-19 is particularly important with those with recent diagnosis of substance use disorder, and not the case with those with a lifetime diagnosis, but not a current substance use disorder. So being currently engaged in abusing different types of drugs increases the risk of being infected with COVID-19. Now, and so having ADHD has a higher risk, having substance use disorder has a higher risk. Now, of course, we can conclude that having jointly these dual disorders increases them at risk. But what is ADHD? ADHD is a chronic neurobiological disorder involving problems of inattention, hyperactivity, and impulsivity. It's highly heterogeneous, both in presentation and in severity, and partly because of its very high comorbidity rates. So that about 80% of individuals with an ADHD has another lifetime diagnosis of any mental disorders. And among them, having a substance use disorder is particularly frequent among individuals with ADHD. ADHD is a lifetime disorder, and along the lifespan, it evolves in different manners. But with in a childhood prevalence of 5 to 7%, it's estimated about 60% of cases continue to be symptomatic in adulthood, so that the lifetime prevalence in adults is between 3 and 5%, which makes it a very high diagnosis. Now, that's even higher in individuals with substance use disorder. So that it has been estimated in different meta-analyses that approximately 20% of individuals going in treatment for substance use disorder have a concurrent ADHD. But not only it makes them more likely to have a substance use disorder, to start using drugs much earlier age and develop more severely substance use disorders, but also they have more likelihood to have more severe problems at all different facets of life. And in addition, actually, it has been shown that individuals with ADHD have a higher risk of premature death of any cause. That is a Danish study published in 2016. But very recently, there is a further study with a large cohort of Swedish individuals showing that not only individuals with ADHD have a higher risk of suicide, but also they have a higher risk. That risk gets even higher when they have other comorbidities. So that among this large sample of individuals that involved 28,000 with a diagnosis of ADHD, having other psychiatric comorbidities increased by up to 25.2 having a premature death. Not only that, but the older the diagnosis, the more severe and the more comorbidities concurrently happening in these individuals, the risk of premature death, including suicide, was higher. And that's even higher in those with adult ADHD. That increases with the number of comorbidities in individuals with ADHD. Now, and among those, there are certain comorbidities that actually increase the risk. It highlights a substance use disorder. So again, having a dual disorder increases by the mortality rate is 79.4 compared to an overall comorbidity of 5.45 if you had only ADHD. So that highlights the importance of detecting and treating individuals with ADHD and substance use disorder. In any case, overall, having ADHD increases the likelihood, the odds ratio of having any mental disorder. So it increases by 2.5 having a major depressive disorder, 7.4 having a likelihood of a bipolar disorder, 3.9 the odds ratio of having PTSD, or 5.5 of having agoraphobia. But it increases between 1.5 and 8% and 8 points the likelihood of having a substance use disorder. So that compared to control individuals, children with ADHD are twice as likely to have a lifetime history of nicotine use, 3 times likely to report nicotine dependence in adolescence and adulthood, almost twice more likely to meet a diagnosis of alcohol use disorder, and approximately 1.5 times more likely to meet criteria for cannabis use disorder and twice more likely to develop cocaine use disorder. So overall, there is an increase between 2 and 3 times more likely to develop a substance use disorder. But we need treatments, and often the problem is that we envisage treatment just one approach to treat everything. And like this old phrase by a journalist, Heinrich Louis-Mencken, we often treat complex problems with simple solutions, and of course they are often simple and wrong. And that applies also to dual disorders. We cannot envisage that treatment can only be with one approach, but rather using multimodal integral approaches, using psychological, psychopharmacological strategies and strategies that target both sides of the dual disorders, I mean, the ADHD and the substance use disorder. And a good approach is actually in these treatment guidelines. This is the Canadian one published in 2018, where on one side it highlights the high comorbidity, the high concurrent risk of having substance use disorder and ADHD, which increases with the presence of a conduct disorder or bipolar disorder. But more importantly, what it actually shows is it provides some guidelines regarding treatment. And of course, it says that treatment needs to be considered simultaneously. But I would like to highlight it even further. And it says that ADHD and substance use disorder need to be treated, as I said, concurrently, but also independently, meaning that we need strategies that are effective for treating ADHD and strategies that are effective for treating substance use disorder. We know that psychostimulants are in generally safe, and they don't have the same abuse liability, the abuse risk as illicit stimulants like cocaine or methamphetamine or speed or whatever type of stimulants. But in any case, the non-stimulants and long-acting psychostimulants have less abuse potential than immediate release ones. So, and we have a plenty different pharmacological approaches of long-acting psychostimulants that are, as I said, very safe and absolutely and extremely effective, even compared to medications used for schizophrenia, for depression, for anxiety, or for bipolar disorder. Now, so that this is Canadian, the Kadri guideline, but in Europe also there has been a European consensus on diagnosis and treatment of adult ADHD, and there is also a paragraph on individuals with ADHD and comorbid substance use. And one point that actually they highlight, and that's based on the evidence of recent double-blind control studies, is that they showed that in individuals with both ADHD and substance use disorder, treatments and medications, including stimulants, are effective. But to be more effective, they have to be used in higher doses than normal. Now, in common practice, the tendency is to use lower doses than normal, and therefore often undertreated. The patients don't respond accordingly, and it looks like it's not working. But and it shows that doses above the normal recommended dose tend to be particularly effective in dually diagnosed patients. Of course, it highlights that immediate release stimulants have to be avoided, but long-acting like oral methylphenidate or lisdexamfetamine or mixed dose and mixed methamphetamine salts, long-acting ones have lower abuse potential. And based on large cohort studies following treatment, the negative outcomes not only are related to a better an increase in improvement regarding ADHD symptoms or substance use disorders, but also regarding functionality overall, lower mortality, lower criminality, lower depression rates and suicide, and of course, lower substance abuse. So treatment is needed and absolutely effective. And a good example is this small but very informative naturalistic study published in Finland a few years ago, where analyzing two groups of 30 individuals, all of them with ADHD, but 30 of them treated as usual, so no specific treatment for ADHD, but 30 of them receiving, in addition to their substance use disorder treatment, a specific treatment for ADHD. And what they showed in their follow-up, which was an average of 18 months, is that individuals treated specifically for ADHD had a much better outcome in several variables. So and these were severe individuals, some of them with involuntary treatments. And there was a better response in terms of moving on to rehab, moving on to better psychosocial functioning than those that didn't get a specific ADHD treatment. And they got better outcomes in terms of employment and in terms of getting to studying. And although not statistically significant, there were 4 patients that died during that follow-up in the group that were not getting specific treatment for ADHD, and only 1 among those receiving treatment for ADHD. So again, showing a clinically significant effect on the risk of premature death. Now, as I said at the beginning, we're in strange times with this COVID-19 pandemic. But of course, where there is difficulties, there are also opportunities to change and opportunities to do things differently. And therefore, there has been some different publication going on. There are ways to strengthen, to modernize, and to complement addiction care systems to avoid what actually happened during the confinement, that treatment for addictions in many places were locked, closed, and patients were not receiving any treatment, were appearing in accident emergency departments and not getting any proper treatment for the substance use disorders. And that applies, as I said, also for ADHD. We've been talking about precision medicine, and that's pointed out in this recent review that's going to be published at the end of the year by Greg Mattingly and his team, that we need to individualize treatment. We need to individualize optimal pharmacotherapy and psychotherapy for patients with ADHD, depending on age, depending on lifestyle, but also depending on comorbidities, and that includes substance use disorders. And we have enough, or we hope to have more, but we have several options to individualize treatment depending on patients' needs, and that needs to bear in mind. It doesn't apply everything to everybody, but patients need to be getting what they need depending on what we have. And particularly to avoid this revolving door syndrome that patients with dual disorders often suffer, and going from mental health services to substance use disorder treatment services and not getting any proper treatment anywhere because they are more complex. Well, I would like to thank you for your patience and for your attention, and invite you to our forthcoming Congress of the Society of Dual Disorders. And as I said, thank you very much for your attention.
Thank you very much, Dr. Martinez-Raga, for your kindness, accepting to talk without slides. We beg your pardon for this, but I must say that you have a high capacity, didactic capacity, because you have been talking very clearly.
Thank you.
Without the help of your slides. And well, it's very important that you have.
Oh, sorry, you didn't see my slides.
Well, at least I have not.
Oh, okay, because I was sharing my computer, and I thought that you were seeing my slides.
I don't know the
rest
of attendance, but I have been only with your first slide, no, the slide of Nora Volkov, and the rest I have not seen.
Well, I was passing all my slides as well.
But
okay,
you speak so clear that it has been exactly if I was really reading your slides. Thank you very much, Pepe. Thank you very much. We are now at the end of this third webinar, and I would like to thank very much all the speakers that has participated and the colleagues that has been following us. In this webinar, we have reviewed many different topics. All the topics very relevant when we try to understand the dual disorders phenomena. Dual disorders phenomena, that it's a comorbidity, still not very well recognized in classical psychiatry, and also sometimes not accepted. I will give a special thanks to Professor Mary Price the organizer of the Congress. All of us that has been organizing Congresses, we know that it's very difficult to organize, and you are suffering until the Congress is ending. Thank you very much, Mehdi, for your kindness. And also I would like to thank my co-chair, Dr. Nadia Kadri, that I will give now the possibility to end this webinar and say all of you bye-bye until tomorrow. Nadia?
Thank you, Professor Miguel Casas. And my turn to tell thank you to everybody who participated to this first part of our Congress, because we have three more days working on the National Congress of Moroccan Private Psychiatric Society. And thank you for of us. Thank you for Professor Paez, who made a lot of energy and work to prepare these sessions. And I would like to invite him to close the session and this part of the Congress by giving us some words. Professor Paez.
Yeah, thank you, Nadia. Thank you, Miguel. I know that is perhaps very early somewhere, but it's very late in another place, and that will be brief. Just to say that, as Miguel says, it was a very, very rich Congress who remind us that this topic, dual disorders, addiction, and relationship with psychiatric disorders, is a polyphacetic and very complex issue. We have learned a lot of things, a lot of important things we have learned during this Congress, and he showed us also that more research is needed. I would like once again to thank everyone who made this fourth Congress of WADD possible, mainly the speakers. And I give you rendezvous appointment in next 5th Congress of WADD will be held, I hope, really or virtually with Albatros in June next year. And I hope to welcome all our friends from abroad to have the possibility to meet them in Morocco, in Marrakesh, or otherwise. Thank you, good night, and see you later. Bye-bye. Bye-bye.
Bye-bye. Bye. Thank you very much.
Bye-bye. Thank
Bye.
you.
Bye.
Nestor, thank you. Bye-bye.
Nestor.
Thank you too.
Bye-bye, Nadia. Bye-bye.
Bye.
Bye-bye. Thank you.